of you have done this test before. So I will ask from you, what was your response in particular questions? So first question is, a 69-year-old gentleman is admitted to hospital for treatment of aneurysmal SH. On third day of his admission, he developed dyspnea and substernal chest pain. Electrocardiography shows anterior lead ST elevation. Lab investigation reveals mild elevation in troponin levels. However, no angiographic evidence of obstructive coronary disease or acute plaque rupture is found on examination. Suddenly, he develops hypotension of 80 to 55 millimeter of mercury, and echocardiography shows a moderate left ventricular outflow tract obstruction. Which one of the following treatments should not be recommended for this gentleman? So, what was your answer in this question? Anyone? Any of you who have done this question? No. So answer is A, inotropic agents. Because all patients with stress-induced cardiomyopathy who develop shock need urgent echocardiography to evaluate left ventricular outflow tract obstruction. In this question, you have to see that alpha agonist may improve hemodynamics, beta blockers may resolve obstruction, and inotropic agent will increase the contractility and will inotropic agent will increase the outflow tract obstruction, so should not be used in this situation. You can use beta blockers, alpha agonists, or in case IABP. But you should understand that afterload reduction can exacerbate the obstruction. So you have to use carefully these devices like IABP. But answer is inotropic agents, because that will lead to increase in contractility and that will increase the left outflow tract obstruction. Is there any confusion? Please ask. So otherwise I will move ahead to the next question. So 56-year-old gentleman is admitted to ICU following a Whipple procedure for a pancreatic cancer. He has a history of IV drug abuse and regularly takes methadone for pain relief and as treatment of his drug addiction. In case of severe pain, he takes hydromorphone as acute analgesia and cefazolin as antibiotic prophylaxis. 12-lead ECG done in morning shows a QTC interval of 510 millisecond. Therefore, at that morning, the rhythm shown below is observed. Which one of the following is most pertinent next intervention? So, what is the diagnosis of this ECG? Can anyone tell? This is a prolonged QT interval, or maybe Torsades de Pointes. So you should know the causes of increased QT interval, or when QTC interval more than 500, it leads to Torsades de Pointes and can cause sudden death. So treatment is magnesium sulfate for Torsades de Pointes, and amiodarone would be harmful because it could actually lower the heart rate and increase the QT interval. Bicarb has no role in QTC prolongation. And if you remember the drugs causing increased QTC prolongation, so methadone is one of them. So methadone could lead to prolonged QT syndrome and it should be discontinued. Rest other options are not correct. Then a 59-year-old gentleman is admitted with an advanced heart failure. He had a left ventricular assist device placed 3 days ago as a bridge to transplantation. His intraoperative course was uneventful and he was uneventfully extubated 24 hours ago. His pump speed has remained 9,600 revolutions per minute and power has remained 5.7 watts. His last documented flow was 4.8 liter per minute. Heart has remained in normal sinus rhythm. On-duty physician is called to the bedside by nurse, who has now noted an acute decrease in cardiac output. There have been with the device machinery, or which of the following would be consistent with the developing situation of cardiac tamponade? So they have given already the cause of decrease in cardiac output, that is a cardiac tamponade. Now they want to know what are the pressures on the right and left side are high or low. So among these options, CVP should be high in cardiac tamponade, PA pulmonary artery pressure, pulmonary artery occlusion pressure, and mean artery pressure will be low in cardiac tamponade. And echocardiography, there is a compression of the right ventricle. So option D is correct. CVP is high, PAP low, PAOP low, mean arterial pressure low, and echocardiography is showing right ventricular compression. Other options are not correct, because in cardiac tamponade, you know, the diastolic pressures, all four chambers of heart are equal. So other options, CVP high, PAP high, it's not correct. POP high, not correct. And C option is saying CVP low, it is not correct. E option is saying PAP high, it is not correct. RV dilated to pulmonary embolism. So in cardiac tamponade, CVP will be high, PA pulmonary artery pressure, pulmonary artery occlusion pressure, MAP will be low, and there will be right ventricular compression because of cardiac tamponade. Then next question. A 69-year-old lady undergoes a left carotid endarterectomy for clearance of a left carotid artery stenosis. After 3 hours of procedure, she is found to be increasingly drowsy. When aroused, she complains of having a left-sided headache. On examination, her blood pressure is 180/100, heart rate is 72 beats per minute, and respiratory rate is 20 breaths per minute. Which are the following most appropriate intervention in this scenario? So what is the diagnosis? Diagnosis is cerebral reperfusion syndrome, because lady undergoes a procedure of left carotid endarterectomy. So what will be the best thing in this situation? A narcotic for analgesia, administer labetalol to control hypertension, obtain transcranial Doppler to assess possible vasospasm, obtain a head CT to rule out ICH. So answer is B, administer labetalol to control hypotension. So cerebral hyperperfusion syndrome following carotid and classically occurs 2 to 3 hours postoperatively. Ipsilateral headache, eye pain, somnolence, agitation, confusion, and seizure. It is thought to be a result of impaired autoregulation distal to stenosis, resulting in excessive blood flow and removal of after removal of stenosis. So in this case, treating symptom with additional narcotics would be beneficial. Only BP elevation is the result of surgical pain. So which is not like in this case. Radiographic and Doppler imaging in absence of lateral neurological deficit are not warranted. So answer is the administer labetalol to control hypertension. Then a 41-year-old lady is placed on a peripheral veno-arterial ECMO using femoral artery and vein catheters for worsening cardiogenic shock due to viral myocarditis. During the following week, her indigenous cardiac function appears to be improving, although she developed VAP and is being treated with broad spectrum antibiotics. ABG showing pH is 7.48, PaCO2 32, and PaO2 60. Oxygen saturation 90% on FiO2 0.6, PEEP 7.5, tidal volume 450, respiratory rate 18, chest X-ray showing right middle lobe and left lower lobe infiltrates. Post-oxygenator ABG showing 7.40 pH, PaCO2 40, PaO2 300. Nurse alerts the attending physician about the patient declining oxygen saturation throughout the day and low partial arterial oxygen pressure. Which one of the following is the most appropriate next step to be incorporated in the management? So the important thing is that patient's PaO2 is 60 millimeter of mercury on FiO2 of 0.6 and oxygen saturation is 90%. You can see the post-oxygenator ABG is PaO2 is 300. It means oxygenator is working properly. So there are two options. One is change out the oxygenator and D option, add a second oxygenator to the circuits, are wrong, because oxygenator is working properly. So what other options? Increase the ventilator FiO2? No. Convert the veno-venous ECMO? Maybe. C and D are wrong. Consider changing to central VA ECMO or increasing circuit flow. This is the best option. Either you can change the veno-arterial ECMO or increase circuit flow, because the diagnosis is north-south syndrome, or it is known as Herculean syndrome. In VA ECMO, if there is a differential hypoxia, which is known as north-south syndrome or Herculean syndrome, in this situation, there is an adequate native cardiac function with concomitant respiratory failure. In this situation, you can use the pre-oxygenator and post-oxygenator ABG, and you can understand the post-oxygenator ABG is perfectly fine, but pre-oxygenator ABG is not like in this case. So solution of this problem can be change the central cannulation. Somebody is saying, sir, we can increase ventilator FiO2 also in Herculean syndrome. We can do that, but the most important thing is that change to central VA ECMO or increase the circuit flow. This is the best option. So based on post-oxygenator blood gas value, oxygenator is working effectively, does not need to be changed, nor does additional one needed to be added. Increasing the FiO2, which is already at 60%, would be suboptimal for a patient with ARDS, because it can lead to oxygen-free radical toxicity. This is the answer of your query. If you will increase FiO2 more than 60%, then obviously free radical toxicity will be more. That's why increase in FiO2 is not the right choice. Then 68-year-old lady on post-operative day 2 of total hip replacement surgery is transferred to ICU with a chest pain and new onset hypotension. On arrival to ICU, sees ephemeral. You are saying there is have only one right, and is it only one right answer? Okay. So we should go back to the question. So first option, increase the ventilator FiO2. This is not the right thing. Convert to veno-venous ECMO. Change out the oxygenator, wrong. A second oxygenator to circuit, wrong. VA ECMO or increasing circuit flow. I think this is the best answer, or nothing is not important. So only one answer is correct, because increasing the ventilator FiO2 will lead to the free radical oxygen toxicity. That's why it's not correct. So in exam, you have to go for the best option. It might possible 2 or 3 may be right, but you have to go with the best possible option. A 68-year-old lady on post-operative day 2 of total hip replacement surgery is transferred to the ICU with a chest pain, new onset hypotension. On arrival to ICU, she is ephemeral with a blood pressure of 88 to 65, pulse rate 74, respiratory rate 20, oxygen saturation 98% on room air. She is sweaty and confused, but is able to state that her chest pain is 9 out of 10. ECG obtained on ICU admission is shown below. Can you see the ECG? And can you tell me the diagnosis? Anyone? Which of the one of the following medications should be administered while awaiting arrival of cardiology team? Options are IV diltiazem to target heart 6, IV morphine, reduce chest pain, aspirin 162 to 325 milligram immediately. So what is the diagnosis of this ECG? Aspirin. You can answer, you may be right, but what is the diagnosis? So diagnosis is inferior wall MI. You can see the ST elevation in lead 2, 3 and AVF. and the reciprocal changes in first and AVL. That's why it's a inferior MI. And inferior MI, if lead 3, ST elevation in lead 3 is more than lead 2, it's a right ventricular infarct also. Or in right ventricular infarct, nitroglycerin is contraindicated. That's why option C is wrong. So in any MI, you have to give aspirin immediately. So answer is D. Is there any confusion? So it's an inferior STEMI with cardiogenic shock, and there is a right ventricular infarct also. Why right ventricular infarct? Because in lead 3, ST elevation is more than ST elevation in lead 2. So this is the case. You can see this ST elevation in 3 more than 2. That's why right ventricular infarct is there. And that's why option C is wrong. Nitroglycerin is contraindicated in right ventricular infarction. Then which one of the following assertions is true about perioperative 5-lead telemetry monitoring in non-cardiac surgery patient? Lead 2 has superior sensitivity for MI compared to lead V5. Lead V5 has superior sensitivity to rate and rhythm disturbance compared to lead 2. V4 has less sensitivity than lead V2. 2 and V5 has equivalent sensitivity for myocardial ischemia. Lead 2, V4 and V5 when used together have superior sensitivity to detect myocardial ischemia. Option E is correct. Lead 2, V4 and V5 when used together have superior sensitivity to detect myocardial ischemia. It's a sensitivity in a tune of 96%, which increased to 100% if you add V2, V3 also. So combining lead 2, V4 and V5 has the 96% sensitivity to detect myocardial ischemia. Then which one of the following agents is most appropriate to administer when a patient with an ECG shown below develops atrial fibrillation with rapid ventricular rate? So what is the diagnosis of this ECG? What is the diagnosis? Then only you can give the answer. This is a pre-excitation syndrome, or you can see a delta wave. This is the delta wave. So what is the diagnosis? WPW syndrome as evidenced by short PR interval and presence of delta wave on the ECG. You are saying answer adenosine. No, because in a WPW syndrome, 4 drugs are contraindicated which decrease the heart rate, decrease the rate. 1, A, B, C, and D means adenosine, beta blocker, calcium channel blocker, and digoxin. These 4 classes are AV nodal blocking agents, and it should be avoided in the case of fast conducting accessory pathway as in WPW syndrome. So you should not use A, B, C, D. A is adenosine, B for beta blocker, C for calcium channel blocker, and D for digoxin. These 4. So metoprolol is a beta blocker, dilgin calcium channel blocker, sotalol beta blocker. So A, B, C, D you should not use. So which option is remained? D, digoxin not, adenosine no, metoprolol no, verapamil no. So answer is procainamide. Procainamide is typically infused intravenously as 20 to 50 milligram per minute, and monitoring blood pressure every 5 to 10 minutes until arrhythmia terminates, hypotension ensues. The QRS is prolonged by more than 50%, or a total of 70 milligram per kilogram has been given. Even if it does not result in tachycardia termination, IV procainamide will usually slow the tachycardia rate and improve hemodynamic state. If patient is hemodynamically unstable with this type of ECG, so you will use synchronized cardioversion. Otherwise, you can use the injection procainamide.